My name is Donna Ockenden. I'm co-clinical director of the London Maternity Clinical Network. I've been working in and around women's healthcare for around 30 years and seen many changes, most of them positive and much improvement. We know that there's evidence of excellent and compassionate care, with some fantastic purpose-built maternity bereavement services, allowing families to remain together at a really difficult and tragic time for them. The issue is that these are not universal across England, and many midwives on the ground tell me of having to make do and mend to do their best with maternity bereavement care without necessarily having the resources that they need to hand. Training around bereavement care is often a low priority, and midwives tell me that training programs are put in place, they last a while, and then as funding is cut, they disappear. On June the 22nd, we launched the Maternity Bereavement Experience Measure, or the MBEM, providing practical methods for staff to gain feedback from families around bereavement care. We did it because staff tell us that gaining that feedback is often a very difficult piece of work to undertake. But now that we have a methodology for ensuring we get feedback, I believe that we need to go further, make sure that feedback is used, and that the information that families give us is sustained into everyday care. My view is that we need to start from the top of every organisation and at the same time work up from the bottom. So everyone who sees this MBM can ensure that it's shared with commissioners, with trust provider CEOs, the chairman and non-exec directors. All acute trusts and CCGs will have a quality section of their executive meetings, and there needs to be commitment noted to the MBEM at those meetings. Working from the ground, service users and clinical staff can work with this MBEM with a shared purpose. Family stories, particularly around bereavement care, are moving and powerful, but I believe that they must be used cautiously and with purpose. By that, I mean that where family stories are shared, they must be used in order to improve care and sustain that improvement in care on the ground. Charitable funds are available across all NHS trusts, and maternity staff on the ground can be supported to ensure they are used creatively to fund, for example, training for all, training that is sustained. And by all, I mean everyone within the maternity team who may have any contact with bereaved parents. That includes housekeepers, porters and consultants. I feel really strongly that second best in maternity bereavement care is not good enough. And I don't believe that staff should need to bake cakes, run marathons, to self-fund bereavement room facilities. The question I would ask is, would you need to do that to fund a CTG machine or a Ventouse machine? The answer is likely to be no. The training provided around maternity bereavement care needs to create that balance between the very special knowledge I know is held by many bereavement midwives and everyone in the maternity team having the skills to relate to and support parents. Remember that many interactions with bereaved parents can happen outside the bereavement suite. It can happen in hospital corridors, in clinics, in administration areas. So therefore, maternity bereavement care is not and shouldn't be a one-person job. There's learning that can be shared across entire women and children's divisions and across the wider trust. By that, I mean maternity working with neonates, paediatrics, the emergency department and the gynecology department to share learning, share experience and all work together collectively to improve care for parents. And of course, mortuary staff, ambulance staff, the chaplaincy team and portering staff all have their individual perspectives and all working together collectively can make those improvements that maternity care around bereavement needs. So listening to midwives and staff working on the ground, it's really important, they tell me, that leaders across our professions take this agenda forward and take it forward as a must-do. This should be a key policy item for all of the Royal Colleges, including RCOG, RCM and RCPCH, making it a must-do rather than a could-do or ought-to-do. I believe that expert maternity care around bereavement is as important as the other key maternity indicators that we discuss daily, caesarean section rates and other such rates that are thought to be and are indeed very important. The clear message that I would want to share is that compassionate, kind and high quality maternity bereavement care must be an always event, not an event that we hope to do better at, that we try our best at, but an always event so that every parent who loses a baby or babies or a pregnancy is supported by experts who have the time and resources to care for them. So at the launch of the Maternity Bereavement Experience Measure, I asked everyone what were their individual pledges around bereavement care and what were they going to do with that toolkit when they went back to their individual trusts. So I've been around maternity bereavement care, had the privilege to support parents now for almost 30 years, and I believe that we've achieved so much, but so much remains to be done.